3, 2, 1. Please start, sir. We are live.
Very good evening, all distinguished delegates and today's eminent faculty for CLEARTalk, Dr. Suhas, Erande, sir. We are honored and privileged to have you on board this evening talking about bempedoic acid through the lenses of clear outcomes trial. Giving a small brief about CLEARTalk. CLEARTalk is one more facet of United States dyslipidemia. Dyslipidemia is bempedoic acid. Lately, late-breaking clear outcomes trial, which was published in American College of Cardiology 2023, and we have one of the eminent India's best faculty to talk about this clear outcomes trial, Dr. Suhas Erande, sir. Without wasting much of our time, I would like to introduce sir. Sir is MD Medicine, Sasud Hospital in Pune, 1985. Sir as ICMR Research Fellow in Diabetes, practicing as a consultant from last 33 years. Sir is very active in various CME at international, national, state platforms like RSSDI, Epicon. Sir has written book chapters and academic articles for physicians at national and international level. It's very wonderful to see sir is involved in so much of activities. At this age also, we are very fortunate to have him as a speaker, today's speaker for CLEARTalk. Sir is involved in phase 2 and phase 3 clinical trials in diabetes, awarded Diabetes Mitra for social awareness and diabetes education in Pune. Sir is an honorary consultant at Pune Municipal Corporation. So would like to stop here. This is just a brief introduction of sir. So it's my honor to hand over this session to Dr. Suhas Erande, sir. Thank you so much for being with us on this evening.
Thank you, Sushil, for the kind introduction, and welcome all my friends who are pitching into today's discussion on a very auspicious Sunday evening. We are very excited to really look at the important cardiovascular outcome trial called as CLEAR trial, and that deals with, of course, major adverse cardiovascular events. And the drug here is bempedoic acid. So that's the crude title of today's presentation. And this is bempedoic acid through the lenses of clear outcome trial. Now, my friends, we are very well aware that of the centrality of hyperlipidemia as far as cardiovascular disease is concerned. Low density lipoprotein cholesterol remains the Achilles heel for most of the cardiovascular problems, like coronary artery disease, or coronary heart disease, or cerebrovascular disease, peripheral vascular disease. And this spills over into heart failure, diabetes, metabolic syndrome, and so on and so forth. So the principle of managing dyslipidemia has focused on LDL cholesterol lowering, and the theme is lower the better. We already know that. And nowadays, lower the better, longer the better, right? In fact, the prefix is the earlier we start, the better. So the whole statement should be earlier, lower, and longer. Okay, something on the Fast, Furious, etc., of the different movies, and of course of the Olympics. So as we see in the graph, the y-axis is the relative risk of major vascular events, as you can see here, and this is the relative risk reduction. And on the x-axis is the LDL cholesterol, and the LDL cholesterol, of course, here is in millimoles. You are aware that millimole we convert here. For example, 1 millimole per liter is something around 38.7 milligrams per deciliter. And we in India generally measure LDL by the milligram per deciliter. That's why. But more importantly, the relative risk reduction of cardiovascular events that is controlled or that is brought down or curbed by 23%, which is quite high, 23%, with 1 millimole per liter lowering of LDL cholesterols. And this has been demonstrated in various anti-lipid or lipid-lowering drug trials, which have used ezetimibe in one trial, fibrates in 9 trials, niacin, then the cholesterol ester transferase protein or CETP inhibitor in 3 trials, diet interventions, and of course, the bulk is naturally the statin trials, then bile acid sequestrants, ileal bypass, and the new drug, the PCSK9 inhibitor in 2 trials. So various drugs used for LDL lowering, various other methodologies like an operation or like a diet lifestyle also tried for that. And LDL lowering has always proved to be good for relative risk reduction of the myocardial infarction, non-fatal myocardial infarction, cerebrovascular events or non-fatal stroke, and then going on to unstable angina, need for urgent coronary revascularization, and which we are aware that these are called as either 3-point or 4-point or 5-point major adverse cardiovascular events. I will add here very importantly that this maxim, 1 millimole LDL reduction, 23% relative risk reduction of major adverse cardiovascular events, this is valid for a duration, let me tell you, a duration of 5 years. Now, if that longer is something which is projected, if the same is done over a period of 12 years, so 12 years and the LDL is kept at that controlled level, then that 23% relative risk reduction magnifies to 42% relative risk reduction. So it is not only earlier, it is not only lower, but it is longer also. So I have dwelled on the side because this is the real crux of today's meeting. So each millimole LDL reduction gives more CV event reduction according to the number of years in trial and comorbid conditions as well. So year in trial, 1, 2, 3 or more than 6. And as I have just now told you, 12 if it is 12 years in the trial, that is 12% sustained LDL reduction. Then your percentage reduction in risk is 42. 1 year 11, 2 years 24, 3 to 5 33, and more than 6 years 36. That's what. And the risk of non-fatal MI, CAD deaths and stroke over nearly 5 years of treatment is something which is, I have already alluded to that, that's the baseline. And here is that LDL millimole, so 5 millimoles around, I would say around 5 millimoles is something around, let's say, 40 into 5. Okay, so 120 milligram per deciliter. If the patient is cardiovascular disease plus diabetes mellitus, so higher pedestal of cardiac risk, or CVD plus metabolic syndrome or impaired fasting glucose, CVD without diabetes or metabolic syndrome, diabetes without CVD, and no cardiovascular disease, no diabetes. So you can very easily understand that this is a comparator group or reference group, lowest risk. So that's something which is very important. So, and we are very well aware that higher the baseline risk, better are the returns of control of risk factors over a period of time. Management of dyslipidemia is high on priority because the research has happened in the field of lipidology that has taken a pace over the last half a century or so. And for the epidemiologists, for the policymakers, and for the patient or for you and me, practitioners, it is very comfortable, easy, and manageable to look and chase down a given figure. So if somebody has a LDL cholesterol more than 190, then don't look at any etiology, whether it is diabetes, hypertension, metabolic syndrome, impaired fasting, nothing doing. 190 in itself is a huge risk. So start lipid lowering treatment. Okay. So again, chasing the fever. Then somebody is, let's say, starting at, let's say at 100 LDL cholesterol, but he has diabetes and he has hypertension, he has a bad family history, he's a smoker, then naturally we have to bring it down to something like 70. So that chasing the figure is very, very important. And the whole epidemiology, whole randomized clinical trial world has always liked chasing LDL cholesterol down. And as I have shown you in the first slide, reduction in the major adverse cardiovascular events. But keep in mind, right now I'm telling you that the other competing etiologies, like for example, inflammation, very important etiology of the plaque behavior and rupture of plaque. So that is beyond LDL or the numerical value of LDL. So we have to just keep that in mind. So management of dyslipidemia is high on priority. Statins are the whole tenet around which the lipid management revolves. So what are the concerns? The first concern, do all statins users achieve LDL goals as per the guideline recommendations? Concern 2, how to achieve LDL target after maximally tolerated dose of statins? Indirectly, patient is on full dose of or highest tolerable dose of atorvastatin, something like 80 or 40, or rosuvastatin 40 or 20. The patient does not actually attain LDL target despite that higher dose of statin, potent statin. So what do we do? That's the second concern. So the other thing is, do all statin users achieve LDL goals as per the guideline recommendation? So this is what the proof is. So LDL target is based on risk stratification. That is very, very important. I have already started discussing that. So that 190 without any risk factor, you have to treat, because that weightage of single risk factor, LDL 190, is quite high. ASCVD risk calculator wise, more than 20% risk of getting an event in the next 10 years. But if the patient is at a lower pedestal of LDL, but riddled with comorbidities, then his risk goes up. So this is the position of Lipid Association of India. They clear-cut give you a CVD risk stratification. I'm not going to read each and everything, but suffice to say, there are two very important things. We have to look at the risk factors or markers. So age more than 45 or in males, more than 55 in female, family history of premature ASCVD, current cigarette smoker or tobacco use, high BP, low HDL. Other high risk features, diabetes with 0 to 1, major ASCVD risk factors, no evidence of target organ damage, CKD stress 3B or 4, family history of familial hypercholesterolemia, extreme of single risk factor, so LDL more than 190, BP 200 by 120, etc. Coronary artery calcium source, CAC more than 300, non-stenotic carotid plaque, or LP little a more than 50. And then moderate risk, non-conventional risk factors, CAC between 100 to 300, increased carotid IMT, LPA between 20 to 50, or 20 to 49, impaired fasting glucose, increased waist circumference, metabolic syndrome features, HSCRP more than 2, so that's the inflammation parameter, systemic inflammation parameter, and ApoB more than 110. So put your patient in this screening and decide his cardiovascular risk. What are the risk groups? You have calculated the risk. So there could be low risk, 0 to 1 major ASCVD risk factors and lifetime CVD risk less than 30%. Moderate risk, 2 major ASCVD risk factors, low risk groups with more than 1 moderate risk, non-conventional risk factor, lifetime CVD risk more than 30%. Then high risk, more than 3 ASCVD risk factors, 2 major ASCVD risk factors, more than 1 moderate risk, non-conventional risk factor, more than 1 other high risk factor, etc. And very high risk, obviously pre-existing ASCVD, diabetes with more than 2 other major ASCVD risk factors, extreme risk category A, CAD with more than 1 feature of high risk group, or category B, CAD with more than 1 feature of very high risk group, or recurrent acute coronary syndromes or acute coronary events within 1 year, despite LDL less than 50, or polyvascular disease. So these are, you can say, whenever a patient is there in front of you with his lab values, we can always look at these chart and decide his risk factors on risk level also. Now, depending on the risk level, what are the LDL recommendations? These are the Lipid Association of India revised LDL-C targets for Indian population. So extreme risk group, category A, LDL should be less than 50, optimal goal less than 30. Extreme risk group, category B, LDL should be less than 30. Very high risk, less than 50. Very high, only high risk, less than 70. Moderate risk, less than 100. Low risk, less than 100. And then the non-HDL goal, you know very well that the difference between LDL and non-HDL is usually 30. So if it is here 30, then it has to be here 60. If it is here 50, here 80. That's something going on that way. Now consider drug therapy, LDL more than 50 in extreme high risk group. You have to consider therapy. Extreme high risk group, category B, if LDL is more than 30, you have to consider drug therapy, which is very obvious. So if the levels are not here and above that, you have to consider drug therapy. That's as simple. And of course, this is after an adequate non-pharmacological intervention for at least 3 months. So lifestyle and all those. Now comparison of the other world guideline. This is the European Society of Cardiology. Comparison between 2016 versus 2019 guidelines. So again, here also, look at the risk, low, moderate, high, or very high. The LDL targets, as you can see, 115, 115, 100, and less than 70. As you go higher, the risk. And now in 2019, the same for low, 115, moderate. Here there is a modification. So rather than 115, it has been lowered to 100. Here again, high risk, less than 100 once upon a time, now less than 70. And very high risk, not 70 now, less than 55. So this is almost in tandem with our LAI guidelines. So as severe risk increases, need to reduce more LDL. Now, based on revised ESC 2019 guidelines, how many patients do have controlled LDL? And Professor Kaushik Kumar Ray, who is a president of the European Atherosclerosis Society and very highly respected professor of cardiology the world over, instrumental behind and principal investigator of many important trials in the field of cardiovascular medicine. He has observed this and he has presented this in the published this in European Journal of Preventive Cardiology. So European Union-wide cross-sectional observational study of lipid-modifying therapy used in secondary as well as primary care. This is called as Da Vinci study. A cross-sectional observational study of patients prescribed lipid-lowering drugs for primary or secondary prevention. 18 European countries were involved. Total number of patients around 6,000. Primary prevention 3,000, secondary prevention 2,888. An objective, of course, was to evaluate the impact of ESC 2019 dyslipidemia management guidelines on LDL goal achievement. So Da Vinci study overall outcome. As you can very clearly see here, these are the different proportion of patients receiving lipid-lowering treatment, 3.6, 15.8, 27.6, etc., etc. And these are the color indicators. So yellow is low intensity statin monotherapy, brown is moderate intensity monotherapy, red is high intensity statin monotherapy, blue is high intensity statin and ezetimibe combo, pale blue is high intensity statin plus PCSK9 inhibitor combo, and the gray is other lipid lowering therapies. So it has been observed here that 27.6% eligible patients are receiving high intensity statin. So this has to certainly improve. And how many are actually at target? Okay, see less than this is the high intensity statin, and only a few who are actually achieving the target. So that's something which is important. So Da Vinci study further observation statin usage in very high risk patients now. Okay. So this was primary and secondary prevention. Now very high risk patients. Indirectly, this is an introspection for the practices. Are the patients being put on the risk scale? Number one. Number two, are these patients being given an appropriate lipid lowering therapy? And three, are they achieving the target? So these are the three simple questions. So this is the number of very high risk group. We have seen that 5,888 total patients, out of which 2,039 belong to very high risk category. Correct? And the proportion of patients receiving lipid lowering therapy is that way. Again, green is overall, and yellow is low intensity statin, brown is moderate intensity statin, red is high intensity, dark blue is ezetimibe combo, pale blue is PCSK9, and gray is other lipid lowering therapies. As per the revised guidelines, ESC 2019, in very high risk patients, 37.5% eligible patients are receiving high intensity statins. Indirectly, 62.5% are not, and 22% actually that way. So these are the ones, and that is the level which has been achieved. So giving is one level and achieving is another level. So practically 80% of the patients are not achieving the targets. So let us look at concern 2. How to achieve LDL target after maximum tolerated dose of statins is already on board. So how to be effective with lipid lowering therapy in very high risk patients? Let us say these are ASCVD patients. Obviously, check the baseline LDL level now. Now look at that. ASCVD, for example, acute coronary syndrome, stroke, or peripheral artery disease. Second category, familial hypercholesterolemia. And third category, complete statin intolerance. So these are the different patient groups. Now let us actually look at the lipid lowering. So this is a high intensity statin, which can lower the LDL by 50%. That's the definition of high intensity statin. Then high intensity statin plus ezetimibe, you can expect 65% LDL load. High intensity statin plus bempedoic acid, 65 to 70% LDL lowering. High intensity statins, fixed dose combo of bempedoic acid plus ezetimibe. So 3 lipid lowering drugs, 75% LDL lowering. And the most powerful available, high intensity statin, ezetimibe, and PCSK9 inhibitor. You can expect 85% LDL lowering. Similarly, in the familial hypercholesterolemia, different groups of therapies. So high intensity statin, ezetimibe, high intensity statin, bempedoic acid, and proportionate in more and more lowering of LDL. So here, because the familial hypercholesterolemia is something which is very tough for treatment, this is the option. High intensity statin, fixed dose combo of bempedoic acid, ezetimibe, plus PCSK9. So 4 lipid lowering therapies, and you can expect more than 85% of LDL lowering here. And complete statin intolerance, naturally, statins are off board. So here, fixed dose combo of bempedoic acid plus ezetimibe, you can expect 40% LDL improvement. PCSK9, 50 to 60% LDL improvement. Ezetimibe plus PCSK9, 70% LDL improvement. And fixed dose combo of bempedoic acid, ezetimibe, and PCSK9 inhibitor, 3 lipid lowering therapies, you can expect 80 to 85% LDL lowering in complete statin intolerant patients also. That's very important. High intensity statins, you know very well, you are practitioners, it has a low adherence, which leads to higher major adverse cardiovascular events. Patients have muscle pains or maybe sometimes raised CK levels, myocarditis, etc. So observational study of more than 23,240 post-acute coronary syndrome patients who were prescribed high-intensity statin at discharge, that is on the index event. 66.4% of all patients presenting with ACS did not take high-intensity statins after discharge. Very, very significant. More than 50% of patients had drug interruption or end of the therapy within the first month itself after the index events. And non-adherence to high-intensity statin had a strong association with high mortality, 16%. Okay, so we have to certainly give a very serious thought to the prospect of not the high-intensity statin, but an alternative or a diversion from that problem pathway of high-intensity statins and give patients something which they can tolerate, which can bring down LDL cholesterol, and which can improve the major adverse cardiovascular events. So, my friends, you have the new lipid lowering therapy on board called as bempedoic acid. Biochemically, this is ATP citrate lyase inhibitor or ACL inhibitor, a first-in-class lipid lowering drug. It reduces the uncontrolled LDL-C with maximally, this is the approved indication. So patients with maximum tolerated statin dose and still LDL is not at goal, you can add bempedoic acid. Mixed dyslipidemia, familial hypercholesterolemia, high risk ASCVD patients, you can use bempedoic acid. And the American College of Cardiology has given bempedoic acid different grades of recommendation and evidence in different indications. So some indications it is class 1B, some levels it is 2A, 3, and maybe 3B and 3, etc., etc. So that is something which you can always read out depending on what is the indication for using bempedoic acid and the respective level of recommendation by American College of Cardiology. And of course, I have already shown you patients who are statin intolerant, bempedoic acid certainly comes on board in those patients. What is the dose? 180 milligram orally with or without food. So this is how the progress has been, unlocking the confidence nationally and internationally. So February 20, US FDA approved it. March 20, it was approved by European Medicine Agency. August 22, recommended by Lipid Association of India. October 22, recommended by American College of Cardiology. March 23, the CLEAR cardiovascular outcome trial was published. And April 23, it was also recommended by the International Lipid Experts Panel. So that's the progress of bempedoic acid. How does it work? We are very familiar with this because we are very well versed with statins. So this is the citrate, and under the, you can say, influence of the ATP citrate lyase enzyme, the first step, it gets converted to the next, and then the hydroxymethyl glutarate comes in picture, and then there is a downstream. Of course, you know very well that that's the cholesterol synthesis pathway, and statins, they inhibit or competitively inhibit the HMG-CoA reductase enzyme. That's why it controls the LDL cholesterol level. But higher up, this is the bempedoyl-CoA, which is the active drug or active component of bempedoic acid that inhibits this ATP citrate lyase, and that's why it becomes an upstream inhibitor of cholesterol synthesis. The fallouts are that way. The glucuronide conjugates are, of course, going to come in picture through liver. They are going to be going to the kidneys and then excreted. And the very important part, there is no expression of these processes in the bempedoic acid and all in skeletal muscle. So whatever lipid lowering happens, there is no biochemical transaction of bempedoic acid in the skeletal muscle. So there is basically no issue of any muscle related side effects with bempedoic acid. So statin intolerance, which is happening because of muscle pain, myositis, the patient is completely spared of that, very clinically and very fundamentally. Now, we are very well aware that cholesterol synthesis, if it is reduced, then the LDL receptor gets upregulated, that's the hepatocyte membrane, and the systemic LDL, which is circulating, that is caught more by these LDL receptors. So biochemically, we are aware that as like statin, bempedoic acid not only will reduce LDL cholesterol or cholesterol synthesis, but as a sequence or as a consequence, LDL receptor is going to be upregulated. So the systemic LDL will be caught by the hepatocyte LDL-R receptors or LDL-Rs, and they will be metabolized in the hepatocyte. It is to be kept in mind that patients who use bempedoic acid, there is always a watch to be kept on uric acid because that can increase, and we will discuss that in the further slides. So bempedoic acid is not activated in the skeletal muscle as ACSVL1 is not expressed in the muscle. That one. So there is no muscle side effect. Now, management of patient receiving bempedoic acid therapy. Half-life of bempedoic acid is 21 hours, so classic once a day dose. Elimination is 70% excretion through kidney and 5% excretions through hepatobiliary route, less than 2% excretion, unchanged drug through kidney. Renal impairment. These are the patients where bempedoic acid. No dose adjustment is generally necessary, not studied in the ESRD patients. Hepatic impairment. Again, there is no dosage adjustment necessary, but it has not been studied in patients with severe hepatic impairment, child book class 3. So, but there are no concerns. Generally, we will watching this patient. Now, all patients assess serum uric acid when clinically indicated, prior history of gout, increased vigilance for hyperuricemia if you are going to put the patient on BA. Patients more than 60 years of age taking corticosteroids or fluoroquinolones with renal failure and history of tendon rupture, warn the patient of potential for tendon rupture with bempedoic acid use, and advise the patients to rest at first sign of tendinitis or tendon rupture. So monitoring is necessary. Patients more than 60 years of age taking steroids or fluoroquinolones, those with renal failure, history of tendon rupture, discontinue bempedoic acid if tendon rupture occurs. Consider discontinuing if joint pain, swelling, or joint inflammation occurs in any patient. So be on guard. Those patients who are taking simvastatin more than 20 or prava more than 40, avoid concomitant use of BA. Consider lowering the dose of these statins or switching the statins to something else. Pregnant women, we don't have evidence, so don't use. Breastfeeding females, again, we don't have evidence, don't use. And discontinue BA if it is on. Yes. Talk to me after some time. I am giving a lecture. So the important point there is clear outcome trial now, which is a CVOT trial, and Professor Steven Nissen, very famous person because of his own observations in 2007 on rosiglitazone and hazards of myocardial infarction in rosiglitazone users. So the name became famous at that time. Now he is a PI of CLEAR outcomes trial. The long form of CLEAR is cholesterol lowering via bempedoic acid and ACL, ATP citrate lyase inhibiting regimen. This was the late-breaking clinical trial read out in ACC 2023, April this year, and it was published in NEJM. What is the flow of the trial? Global CVOT BA study in those patients who are statin intolerant, but those who have obviously got elevated LDL. So both categories, primary and secondary prevention patients with LDL rise and proved statin intolerance. So screening, a statin intolerant patient, visit 1, this is week 5. Then 4-week running period treatment with single blind placebo. This is visit S2, week 4. Then visit actual start, day 1, and randomization. So one arm went for placebo, 7,000 patients. The other arm, BA, 180 milligrams per day, 7,000 patients. Visits at month 1, 3, and 6, alternating phone contact and clinic visits every 3 months thereafter. Study completion, 1,620 primary, 4-component MACE, at least 810 3-component MACE, and treatment for at least 2 years. So these are the study completions or definition of study completion. Primary endpoint, effect of BA versus placebo on 4-component MACE. And what was the 4-component MACE? Cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization. Minimum of 1,620 primary 4-component events, treatment for at least 2 years. 13,970 patients, phase 3 clinical trial. Okay, so that's the description, background, statin intolerance, raised LDL, qualifying for bempedoic acid, and severe outcomes were not assessed. So that was why clear outcome trial was proposed, designed, and implemented. Now, statin intolerance occurs in 15% treated patients of statins, prevents patients from achieving the LDL goal. We have already seen that even after the acute coronary syndrome, more than 66% patients stop high intensity statin as early as 1 month. We have already seen that. So they are deprived of the cardiovascular benefits of lowering the LDL cholesterol. So BA has come in picture, ATP citrate lyase inhibitor, and BA approved for lowering LDL, but we needed a CVOT trial. So primary and key secondary endpoints, primary endpoint was 4-component MACE, non-fatal MI, non-fatal stroke, coronary revascularization, CV death. Hierarchical testing of key secondary endpoints, what were they? 3-component MACE, MI, stroke, or CV death, fatal and non-fatal MI, coronary revascularization, fatal and non-fatal stroke, CV death, all-cause mortality. And this was sequential testing. And this is the demographic data. I will not read out everything, but of course, you know very well that one arm is bempedoic acid, the other is placebo. All parameters generally need to be matched. Okay, otherwise the statistical significance is diluted. So age is practically same. Body mass index is also practically same. LDL is 139, 139. Median high sensitivity CRP. The interquartile range is 1.2 to 4.5, 2.3 average on both sides. Estimated GFR, again, similar distribution, more than 90, 60 to less than 90. So that is 3, 3A here, and equal number of patients. CV risk category, primary prevention, 2100, 2106. Secondary prevention, 4892, 4872. CAD, PAD, cerebrovascular atherosclerosis. So everything is similar. Diabetes, again, 3,144 in the BA arm, 3,229 in the placebo arm, etc., etc. And what were the observations? Look at that. 4-component MACE relative risk reduction. And what was that? 13%, biostatistically significant. 3-component MACE. What was the risk reduction? 15% relative risk reduction. Again, biostatistically significant. And look at that. The curves, placebo and BA, they start separating fairly early, practically prior to 1 year. Okay, here, even here, or here. So early benefits are seen. Fatal or non-fatal MI, coronary revascularization. Again, here the relative risk reduction is 23% and 19%. Oh, p-value is less than 0.05, quite significant. So among statin intolerant patients, treatment with BA was associated with a low risk of 4-component MACE, 3-component MACE, myocardial infarction, coronary revascularization. Respectively, 4-component MACE, 13% R, that is R relative risk reduction, 15% 3-component MACE relative risk reduction, and 23% relative risk reduction of MI, and 19% relative risk reduction of coronary need of coronary revascularization. Very significant. What was the LDL lowering? 21.7% in LDL. See, you can see that months since randomization, and this is the mean percentage reduction of LDL. So the blue is placebo, and you can see here just at the end of around 3 to 6 months, the LDL was lowered at 21.7%. Very, very significant. At the end of the study, 26.1% lowering of LDL. Very significant. Not only LDL, I have already alluded to the other competing etiology of coronary artery disease or cardiovascular disease, which is inflammation. So with BA, there is 22.2% reduction in the highly sensitive C-reactive protein levels. So you can see that at month 6, 22.2% CRP reduction. At the end of the trial, 19.4% reduction in CRP with bempedoic acid. Very significant. So what are the safety analysis, serious adverse event? They are comparable. Okay, 25.2, 24.9 on the placebo side, barring the even discontinuation, myalgia, it's practically same. Now New onset diabetes mellitus in patients without diabetes at baseline, 16.1 in BA, 17.1 in the placebo. You know very well that that subtle issue is there, new onset diabetes with statin use, and that's the reason why this outcome also was looked at in the clear outcomes trials, but bempedoic acid doesn't really raise that risk. Renal impairment, certainly you can say more 11.5% versus 8.6, and uric hyperuricemia, very obviously we are watchful, 10.9 on the BA side, 5.6 on the placebo side, 3.1 gout versus 2.1. So we will be watchful, no doubt. So BA becomes the first ATP citrate lyase inhibitor and first oral non-statin to demonstrate statistically significant reduction of major adverse cardiovascular events. You know very well that that has been proved with PCSK9, but they are injectable. So they also have their own significant MACE reduction. We have already known those trials. So BA is the first ACL inhibitor, first non-statin oral, successfully giving you a 4-point MACE reduction in patients with or who are at a high risk of cardiovascular disease and documented statin intolerance and elevated LDL-C. So conclusion, my friend, bempedoic acid is an effective alternative for statin intolerant patients as seen in clear outcomes. It is well tolerated. BA was well tolerated in a mixed population of primary and secondary prevention patients, 7,000 of them. LDL and HSCRP both were reduced. BA lowered LDL by 21.7% and HSCRP by 22.2%. There is a subtle risk of incidence of gout and polylithiasis and uric acid raise. We will be watchful for that. Primary and secondary endpoints, the primary endpoint 4-component MACE was reduced 13% relative risk reduction, 3-component MACE 15% relative risk reduction, MI 23% relative risk reduction, coronary revascularization needed relative risk reduction 19%. So BA is an effective approach to reduce major adverse cardiovascular events in patients who have raised LDL, raised cardiovascular disease risk, and those who are intolerant to statins. My friends, let me reiterate that it is a very recent ICMR INDAP finding that the number of diagnosed diabetics in India has gone up to 10.1 crores. Pre-diabetics, that has gone up to 13.6 crores, more than 30%. Obesity, more than 50%. So from this baseline risk point of view, we need to be very, very vigilant. We need to be more focused on A, B, C control in diabetics, B and C control in dyslipidemic patients. Dyslipidemia is something which is the best weight, or they say that amongst the A, B, C, you put money better on LDL lowering because it gives you more return on your monetary investments as far as the major adverse cardiovascular event reduction is concerned. The drug statin is very famous, very well proved by its utility to reduce major adverse cardiovascular events, but we also know that it has got some patients who can't tolerate statins. So bempedoic acid is a very effective way to tackle those patients who can't tolerate statins, maybe moderate dose, low dose, or maybe higher dose, whatever. And clear outcome trials is a cardiovascular outcome trials, which has shown you 13% relative risk reduction of 4-component major adverse cardiovascular event, 23% relative risk reduction of myocardial infarction. So let's use that in appropriate patients and benefit them by a good, significant LDL lowering. My friends, I thank you so much for your participation and kind attention to whatever I spoke about. Thank you so much.
Thank you so much, sir. This is Muralidhar Pandey. I'm a zonal sales manager, sir. I can see there are so many questions which is asked by delegates, sir. I would like to request you to please take care of the same. As per revised ESC 2019 guidelines, many patients have uncontrolled LDL cholesterol, but they don't have any complications. So should I increase the dose of statins or to add bempedoic acid ezetimibe?
Very importantly, this is no question of wait for the event to happen. Very, very important. Don't wait for the event to happen. Because once the event happens, then it is very obvious as far as the LAI risk stratification is concerned, the risk goes very, very high. So till the time the patient is only hypertensive, only metabolic syndrome, maybe pre-diabetes, and LDL is, let's say, something like 110 or 120, why wait? Reduce, okay? And let me tell you now that the formal presentation is over, that it is my, you can say, personal communication and man-to-man dialogue with none other than Professor Raman Puri, who is the head of our Lipid Association of India. And he had actually insisted that he said that, Suhas, you have to write in your patient education books and profess in your social awareness programs that LDL cholesterol in all your diabetics, whether their ECG is normal, abnormal, stress test done, I don't know that. Bring that down to 70. Okay. So it is very important not to wait for complications. Okay. Not to wait for complications. LDL needs to be brought down for most of the patients to a level of 100, if not 70. That's the LAI recommendation. Okay.
Thank you so much, sir. The next question is, I have many patients with type 2 diabetes mellitus and hypertension. So what LDL target should I keep for these patients?
Right. I have already again told you. Look at the LAI. In fact, LAI has a very recent update on their guidelines, 2022, late 2022, early 2023. That's what I believe. And they are very categorical now that try to see on the background of any additional cardiovascular risk factor. Okay. So that can be metabolic syndrome, that can be hypertension, that can be diabetes, that can be pre-diabetes for that matter. Okay. Bring that LDL cholesterol down. Until now, we were saying that more than 50% lowering with high intensity statins, but now LAI says that bring it down to 70.
Thank you, sir. The next question is it appropriate to keep LDL cholesterol below 40 mg per DL as per guidelines recommendations? Can it lead to a neurological complications?
Yeah, that issue has been thoroughly, you can say, discussed. If you are very keen, you can always use the LAI, or you can look at the Journal of Clinical Lipidology. There are very illustrious articles, very interesting to read for the physicians, really. Low, how much low? Okay. And zero LDL policy. So there are very illustriously and very attractively titled articles. Let me tell you that with an extreme LDL lowering, people are always, you can say, having concern about especially neurological issues, maybe some kind of cognitive defects, not exactly Alzheimer, but cognitive defects, and some kind of, you can say, maybe hemorrhagic strokes, varied kinds of, you can say, issues. However, these issues have been very clearly, you can say, followed. There are people who are, of course, they are, most of the time, they are with interventional cardiologists. LDL level has been brought down to 40, 30, 15 also, and they have been followed for a period of 1 year, 2 years, 3 years, etc., without any significant neurological or any other problems. So that's something which is importantly to be appreciated. In fact, that's the paradigm which takes you to the discussion of LDL 30, which is supposed to be the LDL when you are born. The fetal LDL is 30. And that's the reason why that 30 is changed. It's not a golden or, let's say, magic figure. It is because the fetal LDL is 30. That figure is chosen. So no problems.
Thank you, sir. Next question, what I see, if patient is having elevated LDL cholesterol with moderate statin dose, then what should we do? Either to increase the dose of statin or to add the bempedoic acid?
Yeah. There are two answers to that, and the proofs also are that. The clinical pharmacology principle says, and it has been very, very valid with statins that has been presented over the last 1.5 decades also, that if you start somebody on atorvastatin 10 or rosuvastatin 5 or whatever, low dose, let's say, or a standard use in or popular use in Indian physicians' prescriptions, and you expect a LDL lowering of something like maybe 30% or 20%. Now, that has been achieved. Patient has not reached the target. If you go from 5 Rozova to 10 Rozova or from 10 Atorva to 20 Atorva, you will not get that 30% lowering. You will get something which is lesser than that, something like maybe 12 or 14%, 15%. Patient has not reached the target. So you go up from that 20 of Atorva to 40 or 10 of Rozova to 20 of Rozova, something like that. The decrement in LDL or improvement in LDL will be still lesser. That's what is clinical pharmacology. So prudence and wisdom of pharmacology and clinical medicine says that if you are using a popular or a reasonable dose, okay, reasonable dose of statin, the popular lipid lowering agent, patient has not reached the LDL, you are already using moderate intensity statins and patient is not reaching the LDL goal. So you certainly should be thinking of maybe taking him to the full dose of statin, which is a typical reflex. However, prudence says that you use the other ways. Maybe you can add ezetimibe 10 or maybe you can add bempedoic acid 180. It attacks the pathophysiology in a different way. I have shown it. Okay, I have shown it. So the chances that the LDL will reach the target are higher with statin plus ezetimibe or statin plus BA, something of that kind.
Thank you, sir. The next question is, what percentage LDL cholesterol reduction is observed with bempedoic acid along with statins?
Okay, that also I have already shown. Okay.
Right.
It is between 40%. In fact, non-statin intolerant, it is 40%. But it is, if it is been shown in the listing. Let me tell you that if there are multiple, and that's something which is so detailed, mild dose of statin, mild intensity statin alone, mild intensity statin plus BA, moderate intensity statin BA, high intensity statin BA, and what is the respective LDL lowering. You can really go through the charts. I tell you that it starts from somewhere around 15 to 20% and reaches as high as 65%.
Thank you, sir. And next question, what percentage of statin intolerance do you observe in routine practice? Can bempedoic acid be a drug of choice for those patients?
Okay, the latter half is already answered. Okay, the clear outcome trial, because they were the patients who had a high CV risk, high LDL, and they were proven LDL with statin intolerance. So they were entering the clear outcome trial. So whether they should be, okay, VA has certainly chosen itself as a drug of choice in statin intolerant patient by a very robust clear outcome CV outcome trial. Now the first part of the story, is it the this thing? Now how many percent of the patients on statin do get statin intolerance? I will tell you, theory wise, I tell you that if your patient is old, if his muscle mass is poor, if he is hypothyroid, if he is alcoholic, if he has a reduced eGFR, all right. These are the patients who are more likely to have statin-associated side effects, which are probably myalgias, dehydrated patients, etc., etc. Now, the patients who are not having any of these comorbidities and taking statin, still, depending on the dose of the statin which you use. So if you are using a low dose of, let's say, atorvastatin 10 or Rozova 5, you may not really get a lot of statin-associated muscle or any other side effects. But you go higher the ladder, okay? So the more focused you are on LDL lowering to that target of 70, you will naturally be using higher dose of statin. So that is when the clinical side effects certainly start coming to the surface. And that's what I have tried to show you, that the side effects, they are a barrier for the patients to continue higher dose of statins even after the index acute coronary event. But that is the area where BA comes in picture. What percentage, the answer can really vary. I will say that, okay, 20% of my patients get statin-associated side effects. Somebody will say 30%, somebody will say 5%. That figure is not important, okay? Absolutely not important. But you know very well that statin is so widely used drugs in the physician practice, And there are bound to be, you can say, some patients who are going to get side effects. Dose high, comorbidities, I have already told you. And beyond that, some will certainly continue to have some muscle side effects. And that percentage can be 5%, 10%, whatever you have.
Thank you, sir. Thank you so much. Next question, what I'm saying, as per clinical trial data, is it more beneficial to use bempedoic acid in pre-diabetic patient to delay the new onset of diabetes mellitus?
Who told you? Okay. Don't try to twist the words, my friend. The important here is this is an observation which was there with the first established lipid lowering agent, which is statin. Okay. This was primarily observed in the Jupiter trial, rosuvastatin. What was observed is the risk of new onset diabetes in statin users is on a higher side, somewhere between, let's say, 5%, 7% to that tune. But the fine print was, these were the patients who were primarily pre-diabetic. These were the patients who were 70 plus ladies predominantly. So whether to blame rosuvastatin for conversion of non-diabetes to clinical diabetes, the jury is always out. But Professor Naveed Sattar has very, very illustriously teased it out, and he has published that for one new onset diabetes caused by rosuvastatin, there are at least 3.5 to 5.5 cardiovascular events which are prevented. So that issue has been done and tested with. Now, with bempedoic acid, the risk of new onset diabetes is not there. So the word is very clear, because statins have that. This side effect is looked at because BA is an oral agent, lipid lowering agent, and it acts on the same cholesterol synthesis pathway, but higher up the stream. That's why this has been seen. And a lot of statin requiring patients are having metabolic syndromes and all. So any which way they are to be observed for onset diabetes down the line with bempedoic acid, with rosuvastatin, without that, whatever. So don't try to confuse the words. Don't twist the words. I'm being very clear there. There is nothing like, you can say, use of bempedoic acid to prevent conversion of non-diabetes, pre-diabetes to diabetes. You have lifestyle, Indian DPP, dark wing, finished DPP, proved. You have metformin, you have pioglitazone, you have acarbose, you have those illustrious trials and modalities to prevent conversion of pre-diabetes to clinical diabetes, or taking that impaired glucose tolerance to non-normal glucose tolerance. Being very clear and assertive here.
Thank you, sir. This is probably the last question. What could be ideal patient profile for bempedoic acid plus ezetimibe combination along with the statins? Perfect.
So this goes absolutely as a LDL focused and intensive LDL lowering strategy. You are adhering to that strategy, you will certainly need on the top of statin ezetimibe, and on the top of statin ezetimibe BA, because there will be some patients who will not, you can say, be, and that's what actually the Da Vinci observation has told us, that there are quite a few patients who need it, but they are not on the LDL lowering therapy. There are quite a few patients who are on LDL lowering therapy, but it is a mild or maybe moderate statin, not a high intensity. There are some who are on high intensity statin, but they are not achieving the LDL target. So there are going to be different steps. And if the clinician is focused to the guideline, then he will certainly use high intensity statin. Patient is not at target, he will add ezetimibe. Patient is not at target, he will use bempedoic acid. So this is a, you can say, the approach or the stance of the clinician, which is very important. Otherwise, we are very happy. We have put the patients on 5 milligrams of rosuvastatin and we say that, okay, statin is on board. But is the LDL at target? Is the patient restratification done? Is the LDL achieved according to the risk which the patient has? So these three questions you have to answer and then take your call of statin plus ezetimibe plus BA.
Thank you, sir. I have received the last question, sir. Is it safe to use bempedoic acid in mild to moderate CKD patients?
Yeah, that has already been, you can say, shown in my slide. Be watchful. Very important. Be watchful. That has been a clear instruction. It is not a concern, but watch. You have to certainly watch. And we have already shown in that slide that the component of uric acid is something which is important. It's a biochemical fallout of the mechanism of action of bempedoic acid. So be on watch there. And patients of ESRD, it has been very clearly shown in that slide that bempedoic acid has not been studied in ESRD patients. So I will not use in the grade 4 CKD or DKD.
Thank you, sir. Thank you so much. I would like to thank you for your wonderful talk on CLEARTalk for bempedoic acid, especially the Bemdac, sir. And I would like to thank all the
Had to be a
delegates.
clear talk because the name of the trial is clear.
Right, sir. Thank you, sir. Thank you so much for the same, for your time, especially giving on Sunday, and for you giving a wonderful talk on CLEARTalk, sir. And thank you so much to all the delegates for spending their time and attending the session.
And I have a personal thanks to everybody, because I always appreciate that the number of questions is high. That means that probably the participants listening to whatever I was presenting, and other important thing. These are the questions which actually reflect on the thought process of that particular expert. And I'm sure that my insistence that amongst the different risk factors of cardiovascular disease, especially as a diabetologist, I always talk of A, B, C, but I always say that the money should be put in the reverse order. First, concentrate on cholesterol, LDL cholesterol. You will get the best return on your money, followed by BP, followed by HbA1c. And this is coming from a diabetologist. Don't forget that. Thank you so much. And
Thank you, sir.
good night to all my friends, and good night to the team, all Zydus team, for arranging these sessions.
Thank you, sir. Thank you so much.